Hello, everyone. I'd like to first take a minute to thank the organizers and especially Dr. Domchek for the opportunity to give this talk today. Here are my disclosures, none of which are pertinent to the talk that I'll be giving. So today we're going to be talking about managing variable cancer penetrance in CDH1 carriers. It's a topic that almost everyone in the field of cancer genetics has probably had to deal with at some point or another. And so for an overview of the talk, I'll first give a background on this topic, then talk about some of the certainties associated with CDH1, then some of the cancer risks of CDH1 carriers, then we'll talk about management, and finally some CDH1 specific counseling considerations. So let's first start with some background. So when we think about gastric cancer and how common it is worldwide, gastric cancer actually is one of the most common cancers. Focusing on the data for cancer incidence and cancer-related death, it's the fourth most common cause of cancer in males and the third most common cause of cancer-related deaths in males. And it makes the top 10 list for females as well. However, in the United States, the picture is quite different, and gastric cancer in the US is actually fairly rare and doesn't make the top 10 list for new cancers that are diagnosed, nor does it make the top 10 list for cancer-related deaths. However, what is interesting about gastric cancer is that a decent amount of gastric cancers are related, or at least have a familial component. So it's estimated that about 20% of people with gastric cancer actually have a family history of gastric cancer. However, only 1 to 3% of gastric cancers are known to be due to a hereditary genetic risk factor. Of hereditary causes of gastric cancer, hereditary diffuse gastric cancer syndrome, or HDGC, is the most common cause of hereditary gastric cancer, and it leads to an increased risk of both diffuse gastric cancer as well as lobular breast cancer. HDGC is fairly rare with an incidence of about 5 to 10 per 100,000, and the classic feature of HDGC are these signet ring cells, which you can appreciate up here in this top right panel. These signet ring cells can often be found right underneath the lining of the stomach in affected individuals. As far as mutations that can cause HDGC, the most common mutation is CDH1, which we'll go into more detail about later. CTNNA1 is also another cause that's been gaining increasing attention in the cancer genetics community. And Dana Clark from our group published a paper on CTNNA1 and how often it's found on multi-gene panel testing just last year. And then finally, there was a report a couple years ago associating PALB2 with HDGC. However, for the rest of the talk, I'm really going to focus on CDH1, which is the most common cause of hereditary diffuse gastric cancer syndrome. So CDH1 was first identified in 1998 in a Maori family in New Zealand who had multiple affected family members with diffuse gastric cancer. CDH1 codes for this protein called E-cadherin, which is important for cell-cell adhesion. And when you think about cancer risks associated with CDH1, of course, there's diffuse gastric cancer. There's also lobular breast cancer risk. It's been postulated that there may be some colon cancer risk associated with CDH1 mutations. However, that data is still a little bit premature. And CDH1 has also been seen to be associated with cleft lip and cleft palate. And it's been reported that up to 14% of families with a pathogenic or likely pathogenic CDH1 mutation may have some history of cleft lip or palate. So let's move on to talk about some of the uncertainties in CDH1. And I'm going to show a couple of different pedigrees here to kind of illustrate some of these uncertainties. So here are two sample pedigrees here. And so you see on the one on the left, you have multiple individuals who have had gastric cancer. Many of these gastric cancers are of course, diagnosed at very young ages, and the gastric cancers track with CDH1 positivity. Likewise, for this family over here, again, you have several different individuals with gastric cancer with very young ages of onset, even down to age 29, again, tracking with CDH1 positivity. So in these families, these are very classic hereditary diffuse gastric cancer syndrome families where the CDH1 mutation is clearly causing increased gastric cancer risk. However, this does not represent all CDH1 families that we see in practice. Here's an example family of someone who I saw in clinic several months ago. And this CDH1 mutation, which was this missense mutation up here, was identified in the proband's daughter who had lobular breast cancer at age 42. But what you can see is that the proband, as well as his two siblings, were all affected with the CDH1 mutation. Again, all of them over age 70. And there's absolutely no gastric cancer in the family. And you can see the other affected relatives, many of whom are older, and again, who have no gastric cancer in the family. So families such as this really highlight some of the uncertainties about what we know about CDH1 related cancer risks and highlight some of the uncertainties about CDH1 management. So what are these uncertainties? I think we can break them down into several different categories. One, we can think about biological uncertainties. Next, uncertainties related to the risk of CDH1 mutations. And then third, uncertainties related to management of CDH1 carriers. So let's talk about the biology first. So I think the biggest uncertainty in the biology is what causes these focuses of signet ring cells to actually progress to invasive diffuse gastric cancer. We know in CDH1 carriers that these foci of signet ring cells develop very early on, and they can be present very early in life. However, clearly the majority of these focuses of signet ring cell cancer do not actually progress to invasive gastric cancer. And so the role that environmental factors or other genetic factors or epigenetic factors, or maybe there are other risk factors, the role that these risk factors have in promoting this progression, remain a bit uncertain at this point. There are also uncertainties related to cancer risk in CDH1 carriers. So it appears that there may be some high-risk variants, but also some low-risk variants. But at this time, we still don't have enough evidence to really show that a strong genotype-phenotype correlation exists. We definitely need better methods to help risk stratify people into this high-risk or low-risk category. And we definitely need better methods for categorizing the gastric cancer risk in CDH1 carriers that don't otherwise have a known family history of gastric cancer. And then finally, of course, it would be great to have biomarkers that would allow us to detect earlier disease earlier, which could further help inform an individual's future risk. Now, as far as management, again, a lot of uncertainties here. We need better methods for gastric cancer surveillance. We need to better optimize who actually is undergoing risk-reducing surgery. Better management strategies for families who don't have a family history of gastric cancer. And I think, it would be really nice to have a chemopreventive agent that we could potentially give in individuals with CDH1 mutations. But again, these are all uncertainties that we don't have great answers for. So these uncertainties that we see with CDH1 carriers, I think, are even more important in individuals where a CDH1 mutation is discovered unexpectedly. And for anybody that does multi-gene panel testing, you probably have had at least several of these cases where an individual comes in for multi-gene panel testing and they're found to have a pathogenic or likely pathogenic CDH1 variant with absolutely no family history that would otherwise cause you to expect them to have one of these variants. And myself and Dana Clark here at one of the counselors at the Cancer Center, and Susan Domchek, we published this paper in this commentary in JNCI last year, really highlighting a lot of the uncertainties surrounding CDH1. And so all of the primary references, if you're interested, can be found in that commentary. But I would like to highlight some of these uncertainties, especially with regard to unexpected CDH1 variants. And so this was a patient who presented to our clinic several years ago. She was 43 at the time. She had a mother who had a history of pancreatic cancer and endometrial cancer. And because of her mother's family history, she had undergone genetic testing at a different institution. The other, where she had gotten her genetic testing initially, they had ordered a fairly cookie cutter, a 28 gene multi-gene panel test on her. And the patient really did not have extensive pre-test genetic counseling. Well, it turned out that she was actually found to have a likely pathogenic CDH1 splice site variant that I've listed over here on the left. This particular variant had not been reported in ClinVar at the time that the testing was performed. And at the time, there were several other variants that affected this splice site that had been reported as either pathogenic or likely pathogenic. And so a situation like this, again, with no gastric cancer in the family, no lobular breast cancer in the family, it becomes very tough to counsel these patients about what to do. So after extensive counseling and multiple conversations, this patient actually did decide to undergo and proceed with a total gastrectomy. On her gastrectomy specimen, there were actually 2 focuses of signet ring cells that were identified. Once she had these results, other family members then decided to proceed with their own cascade testing. And what we found was that her sister, her niece, and her daughter, as well as her father, all tested positive for the CDH1 variant. Again, after extensive counseling and after the proband was found to have 2 focuses of signet ring cells that were identified, her sister as well as her daughter then proceeded to undergo total gastrectomy. However, in both of those gastrectomy specimens, there were actually no foci of signet ring cells identified. So at that point, seeing that 2 additional gastrectomies had been performed without signet ring cells, the remainder of the family kind of put everything else on pause, and everybody else is currently just in surveillance. But in this setting, again, this is a totally unexpected mutation. We did find 2 focuses of signet ring cells, but we don't know the long-term risk that these focuses would have. And again, then you have 2 other relatives who had gastrectomies who didn't have any focuses of signet ring cells. And so I think this really brings up the question of, through all of this genetic testing, did we really help this family? And so I think to delve into that topic a little bit more, we really have to understand the cancer risks of CDH1 carriers. And we'll talk about the breast cancer risk first. And so the breast cancer risk in CDH1 has remained relatively constant over time, even as more families have been identified. And let's go through that data kind of step by step. So pre-2015, reports of breast cancer risk in CDH1 carriers were around somewhere in the 40 to 50% range. In 2015, there was a landmark paper published by Hansford et al. in JAMA Oncology that showed that the risk of breast cancer by age 80 in CDH1 carriers was, again, about 42%. And then even newer data, including data from Megan Roberts out of GeneDx, as well as from Xavier Lohr's group from Yale, using data from Ambry, found fairly similar rates. So they had found risk of breast cancer in women at 55% and 43% respectively. So what you can see as data has continued to accumulate in CDH1 carriers, that the risk of breast cancer has actually remained fairly constant as data continues to be acquired. However, it's been a little bit of a different story with gastric cancer risk in CDH1 carriers. And in fact, as more families are obtained, what we've seen is that gastric cancer risk has actually decreased over time. And a lot of that has to do with the ascertainment bias that was present in a lot of the early studies looking at gastric cancer risk in CDH1 carriers. So again, going stepwise, pre-2015, gastric cancer risk in CDH1 carriers was high, up to 67% for men and 83% for women. In the 2015 Hansford et al. Paper, it was found that for males, gastric cancer risk was 70%, for females, 56%. And if you go to the newer data, again, these are unselected CDH1 families, you see that risk actually goes down substantially. So it was in the 30 to 40% range in the Roberts et al. Paper, and 37% in the paper that utilized the Ambry data. So what you can see is that over time that the gastric cancer risk has been decreasing. Although it's decreasing, this risk is still obviously incredibly high compared to the average risk population. So why does decreasing CDH1 gastric cancer risk estimates, why do they matter? Well, As we all know, a risk-reducing or prophylactic total gastrectomy has really been the mainstay of gastric cancer risk prevention in CDH1 carriers. And so if gastric cancer is lower than expected, should all CDH1 carriers actually be recommended to undergo prophylactic total gastrectomy? And should gastric cancer risk be managed differently based on family history or by specific gene mutation? And so it certainly brings up these questions, especially as we see gastric cancer risk estimates decreasing in CDH1 carriers. So let's switch gears a little bit and now focus on some of the management of cancer risk in CDH1 carriers. And we'll go back to 2015, and these were the older HDGC guidelines from the IGCLC, or the International Gastric Cancer Linkage Consortium. Back in 2015, when these guidelines were published, if an individual was found to have a pathogenic or likely pathogenic CDH1 variant, it was basically recommended that these individuals undergo prophylactic gastrectomy. For those who refused surgery or would want to delay surgery for other reasons, it was then recommended as a second line that they would then undergo endoscopic surveillance. But really, these older guidelines had recommended prophylactic gastrectomy really as the mainstay of cancer risk prevention for all pathogenic or likely pathogenic CDH1 carriers. These guidelines also recommend annual breast cancer surveillance with MRI starting at around age 30 for all CDH1 carriers as well. Fortunately, these guidelines were updated and were just recently published last year in Lancet Oncology. And again, these are the newer HDGC guidelines published by the IGCLC. And what these new guidelines take into account is that actually we see different types of CDH1 families. So for families where there is diffuse gastric cancer in the families, these are classically thought of as HDGC families. And for these families, it's still recommended that prophylactic total gastrectomy really be the preferred option for gastric cancer risk management in these individuals. For individuals, again, who don't want to undergo surgery or have to delay it, it's then recommended that surveillance be a second line. However, for families that do not have diffuse gastric cancer in the family, if there is breast cancer risk in the family, then these families actually get a different label. And they're labeled as hereditary lobular breast cancer syndrome families. And in this case, the guidelines actually, instead of recommending prophylactic total gastrectomy to all CDH1 carriers, instead favor doing annual gastric surveillance in these individuals. And of course, if signet ring cells are identified on gastric surveillance, then you would consider a total gastrectomy. And really, it doesn't put total gastrectomy as the first line option. For both either HDGC or HLBC, it's recommended that annual breast surveillance be performed with MRI, and that these individuals can consider bilateral risk-reducing mastectomy. Now, for CDH1 patients where there's neither diffuse gastric cancer nor lobular breast cancer, they fall into this other category here on the right. And for these individuals, again, it's recommended that they undergo annual gastric surveillance and annual breast surveillance. It is not recommended as a first-line option and not definitively recommended that all of these individuals should undergo prophylactic total gastrectomy. So I think these were great changes to the guidelines and certainly mirrored the changes that we had been starting to implement already in clinical practice, especially with identification of many of these CDH1 families without a family history of diffuse gastric cancer. All right, so let's next talk about CDH1 gastric cancer risk management strategies. And we really have two options. We have endoscopic surveillance and we have prophylactic gastrectomy. And I'll go into each of these in a little bit more detail. So for endoscopic surveillance, we've classically utilized a protocol called the Cambridge protocol. This involves very close inspection of the stomach as well as targeted biopsies of any visual abnormalities that are seen within the stomach. This is followed by then doing 30 total random biopsies throughout the stomach. And these are done amongst 6 different locations where 5 biopsies are taken from each of the 6 locations. What you can see here is that about half of these biopsies come from the distal stomach, and the other half come from the mid and proximal stomach. However, what we've learned is that more of these signet ring cells, as well as more of these diffuse gastric cancers, actually originate more from the proximal stomach. And so the new method of biopsy, of surveillance biopsy in CDH1 carriers in the new HGGC guidelines, is to actually change the distribution of these biopsies. So now it's only about 10 biopsies are taken from the distal stomach, whereas 20 biopsies are taken from the mid and proximal stomach. In addition to the Cambridge protocol, there was also a newly proposed protocol called the Bethesda protocol. This was initially proposed by Jeremy Davis and his group, and they just published on this earlier this year. And in this protocol, again, they separately sample any areas of abnormal mucosa. And this is followed by then dividing the stomach up into 22 different sites and performing 4 biopsies from each of these sites to give 88 total biopsies that are performed. When comparing the Bethesda protocol to the Cambridge protocol, what they found was that the Bethesda protocol identified signet ring cell foci at a higher rate than those done using the Cambridge protocol. Additionally, the false negative rate for the Bethesda protocol was significantly lower than for the Cambridge protocol. However, it is important to note that a false negative rate of nearly 40% is still far from ideal. Now, many other advanced endoscopic techniques have been utilized to try to improve detection rates in CDH1 carriers, including chromoendoscopy, narrowband imaging, endoscopic ultrasound, which was performed by our group and was published last year, as well as confocal endoscopic microscopy, which is an ongoing study down at the NIH. However, despite all these advanced endoscopic techniques, none of them have been found to be appreciably more helpful for early identification of signet ring cell foci and early gastric cancer in CDH1 carriers. Now, how about talking about surgery a little bit? So when you think about prophylactic gastrectomy, for those in the audience who may not think about the GI anatomy very often, in CDH1 carriers undergoing prophylactic gastrectomy, of course, the entire stomach is removed. Once the stomach is removed, it's then necessary to create a esophageal jejunal anastomosis, as well as a rulin here to allow the pancreas and the biliary ducts to drain appropriately. Now, this is a very big surgery with significant morbidity. And there's also a small but not zero risk of surgical-related mortality. Post-operatively, these patients also have many different risks, including surgical complications, really lifelong symptoms, and then lifelong issues with nutrient deficiencies as well as bone health issues. So this is definitely a surgery that should not be taken lightly when dealing with CDH1 carriers. Now, Vivian Strong and her group at Memorial Sloan Kettering just published their outcomes on prophylactic total gastrectomies in CDH1 carriers last year. And what they looked at were 101 CDH1 patients who underwent gastrectomy. And what you can see here is that about 16% of these individuals had a major, what they considered a major postoperative event in the acute period, so in the first 30 days after surgery. Many of these are very significant findings. So one patient actually died related to the surgery. Several others needed other types of surgical interventions, especially due to leakage either from the anastomosis or the duodenal stump, and others required surgery for other reasons. In addition, about 18% of patients had major late complications, and this is 1 to 3 months after surgery. So these results really go to show that total gastrectomy is a major procedure that carries a substantial amount of risk for the patients. And therefore, patients need to be properly counseled before undergoing such a procedure. And so when we compare the two, endoscopic surveillance versus prophylactic gastrectomy, what do we know? We know endoscopic surveillance is not very good. And a negative endoscopic surveillance exam certainly does not rule out that there may still be underlying cancer in the CDH1 carrier. If somebody does undergo endoscopic surveillance, if that surveillance is positive, they really need to consider total gastrectomy. And it, of course, is possible, even if you have normal surveillance exams, that you could still develop incurable metastatic cancer between exams. When you think about prophylactic gastrectomy, this really is the only way that we have of completely preventing gastric cancer development in CDH1 carriers. However, this procedure does have significant morbidity, and it has a low but not zero risk of surgical-related mortality. And so going back to these management guidelines, I think that these new guidelines from the IGCLC, really break it down nicely and mirror what we've been doing in clinical practice. So CDH1 carriers from families with diffuse gastric cancer, really, I think, they should be recommended to undergo prophylactic total gastrectomy. But in the absence of gastric cancer in the family, I think that annual gastric surveillance should be offered to these patients. Of course, after extensive counseling of the uncertainties regarding the benefit of gastric cancer surveillance in these individuals. And so finally, I'd like to touch on a few counseling considerations associated with CDH1. So, of course, as we're doing more and more multi-gene panel testing, we're identifying more and more CDH1 carriers. And many of these are what we would consider unexpected CDH1 carriers. So they don't have a family history of diffuse gastric cancer and don't have any history of lobular breast cancer. And so basically, I think unexpected CDH1 variants really are unavoidable. So for CDH1 families that have a history of diffuse gastric cancer, I think the counseling of these families is easier. And I think there's less hesitance to undergo prophylactic total gastrectomy amongst these families. For families without a history of diffuse gastric cancer, I think the counseling of these families and the choices they have to make are far more difficult. I think families that don't have any history of diffuse gastric cancer and also who did not receive appropriate pre-test genetic counseling, I think that these are some of probably the most challenging discussions and decisions in all of medicine. So my philosophy is if you can't prevent discovering these unexpected CDH1 variants, I think at a minimum you should prepare testing candidates for the potential of discovering a CDH1 variant. And so our approach here in our GI Cancer Genetics Clinic is that we really emphasize that pretest counseling for CDH1 is really critical. And I think it's important to highlight the lack of effective screening, the potential recommendation for a gastrectomy if a CDH1 variant is identified, as well as emphasizing, how these uncertainties wouldn't just affect the patient, but also potentially the patient's relatives as well. In our GI Cancer Genetics Clinic, we do single out CDH1 on multi-gene panel testing and really provide very specific pretest counseling, kind of expanding and elaborating on the potential for an unexpected CDH1 variant. If after hearing all these uncertainties, if a patient is willing to undergo CDH1 testing as part of other testing on a multi-gene panel test, there's really not much else that this individual, I think, would really want to actually exclude from their multi-gene panel test. And then finally, we also offer selective removal of CDH1 from multi-gene panel testing based on patient preference, especially after a discussion of the CDH1 uncertainties, patients really don't want to undergo that testing because ultimately we want to give the patients autonomy over their care. So hopefully today I've given you a lot of some information and thoughts to chew on with regarding to managing variable cancer penetrance in CDH1 carriers. And I'm going to leave you with just one more case to ponder. And this is a young gentleman who I saw in clinic fairly recently, who had genetic testing as part of a promotion through his work. Now, there's absolutely no gastric cancer in the family. He did have a brother and a grandfather with a cleft lip and palate. And he came back and he was found to have this CDH1 missense variant over here. Now, this again is one of these families that it's very, very difficult to counsel. And unsurprisingly, as we cascade tested his family members, it did tend to track with his brother who had the cleft lip, as well as from his paternal side with the paternal grandfather who had the cleft lip. But again, with no gastric cancer in the family, no lobular breast cancer, management of this individual is certainly going to be challenging moving forward. So thank you so much for your attention. I think this is an area that's really ripe for discussion, and I look forward to having some additional discussions about this topic during the upcoming panel discussion. So thank you so much.